Welcome to Pathology Central Key Concepts. The topic of this video is congenital heart disease, left to right shunts. Now there's a second video on right to left shunts. This is a good one to start. So in order to understand left to right shunts, it's important to review the fetal vascular system so that we understand how these develop. I'm next going to compare and contrast the congenital heart diseases that lead to left to right shunts and finish by discussing the clinical consequences of these lesions. So let's begin first by looking at the fetal vasculature. So here we can see sort of an overview where we have oxygenated blood from the placenta here in the umbilical vein, bypassing largely the liver through the ductus venosus, and then entering the right atrium through the inferior vena cava. Now let's zip over here to our larger magnification. So this oxygenated blood is going to come in through here, and much of it is going to just cross right through the patent foramen ovale into the left atrium, where it can then be sent to the systemic circulation. Some of this blood is going to mix with deoxygenated blood from the superior vena cava, and that blood can come down here into the right ventricle, up into the lungs. Some of that will bypass the lungs and go through the ductus arteriosus because, as you know, the lungs aren't doing much breathing there in the uterus, and so there's not much need to send a whole lot of blood there, so this will go systemically. Some of it does go to the lungs, which do need their oxygen after all, and deoxygenated blood from there will enter the left atrium, down into the left ventricle, and through here. All right, so the important thing to recognize here is that we have three communications whereby the fetal blood bypasses the liver and the lungs. So we have our ductus venosus here, we have our foramen ovale here, and we have our ductus arteriosus here. And these two, the ductus arteriosus and the foramen ovale, are going to show up in our left to right shunts. So there are three general categories of congenital heart disease. We have left to right shunts, right to left shunts, and obstructions. And this video is going to focus on the left to right shunts. Now I have an example of one here. This is a ventricular septal defect. And this is going to allow me to show you in general what happens with left to right shunts. So as you recall, in the healthy adult, the left ventricle is supplying the systemic circulation, and it's pushing against all of that blood, the columns of blood in the body. It's got to be a muscular organ. It's pushing against pressure. So there's a fair amount of musculature here. By contrast, the right ventricle is just pushing into the pulmonary circulation, which has a very low pressure, and it doesn't have to press very hard against it. So this is going to be a thin wall that is not particularly robust. Now, if you think about this, you have a space between these two. One side is pushing very hard, the other not so much. That's going to cause a lot of blood to go from the left ventricle into the right ventricle. Where's that blood going to go? It's going to go into the lungs. So now we're going to be getting increased blood into the lungs with increased pressure. And I'll talk a little bit about where we see the difference between atrial septal defects and ventricular septal defects. That increased pressure, increased volume going into the lungs is going to cause an increase in pulmonary vascular pressure. And this is going to build over time, and at a certain point, you're going to end up with this pressure is so high that we're going to get equalization across these two chambers, and eventually we can get a right to left shunt, and this is called Eisenmenger syndrome. And I'll talk about that more in a moment. So before we go any further, I just want to show you a table that looks at the different congenital heart defects. The left to right defects that we'll be looking at in this video, ventricular and atrial septal defects, as you can see, are some of the most common congenital heart defects. The patent ductus arteriosus is also quite common. Okay, so let's begin by talking about the general characteristics of left to right shunts. So as I already mentioned, it's the most common congenital cardiac malformations. And the ones that we're going to focus on in this slide are atrial and ventricular septal defects. In atrial septal defects, you're going to increase the right ventricular and pulmonary outflow volumes. So more blood is going to be flowing across these areas. However, you're not significantly increasing pressure. With ventricular septal defects and with the patent ductus arteriosus, not only will you be increasing blood flow, but also pressure. So this is going to have a bigger impact as far as driving you towards Eisenmenger syndrome. Now, depending on the size of the defect, patients may be completely asymptomatic. In fact, it may not be diagnosed in life. It may be an autopsy finding. Or you can have individuals who have fulminant heart failure. Now, as I mentioned, I'm going to do this a few times because it is very important. This increased pulmonary blood flow is going to increase our pulmonary vascular resistance, and that's going to, at some point, overcome our systemic vascular resistance, leading to mixing of the blood and cyanosis. All right, and that is Eisenmenger syndrome. So again, we have a left to right shunt, such as an atrial septal defect, ventricular septal defect, or patent ductus arteriosus, increasing our pulmonary blood flow, increasing our pulmonary resistance, pulmonary vascular resistance. When that happens, the right ventricle, usually sort of thin-walled and floppy, is going to start building up and becoming stronger and thicker. And there's also going to be, because of this higher pressure, we have the risk of atherosclerosis in the pulmonary vasculature. I encourage you to watch the atherosclerosis video to make that link between endothelial injury and atherosclerosis. And it doesn't actually, the pulmonary vascular resistance doesn't have to overwhelm the systemic vascular resistance. It can be more or less equal. That's going to cause blood to mix back and forth. And then as it gets higher, we get to our right to left shunt. So how do patients with Eisenmenger syndrome present? Oh, by the way, this is also called tardive, which means late, cyanosis. And this is in contrast to what we see in right to left shunts, and that's a separate video. So individuals with Eisenmenger syndrome, because we go from a left to right shunt to a right to left shunt, we're going to end up with cyanosis because deoxygenated blood is going to enter the systemic circulation. Clubbing, which is not a fun activity that one does on the weekends, but is rather a physical exam finding of the fingers and toes, it's associated with low oxygen tension. And you can see here that the nail is very curved and that this angle has changed between the nail bed and the nail itself. The fingers can appear somewhat bulbous and warm. This is not pathognomonic for pulmonary hypertension. We can see it whenever we have low oxygen tension, so you can see it in cystic fibrosis or in individuals with pulmonary carcinoma. Cardiomegaly is going to occur because we have the right side of the heart is going to have to hypertrophy to push against that increased pressure. And we also will get a development of collateral vessels and increase in diameter of the bronchial arteries. And with this can come hemoptysis, so patients may begin coughing blood. So let's talk now about patent foramen ovale and atrial septal defect. Both of these are going to be in the atrial septum. So remember from what we just discussed regarding the fetal vasculature that in early gestation we have atrial openings that's going to allow oxygenated maternal blood to flow from right to left. And we have the ostium primum and the ostium secundum, which together form the foramen ovale. And in late gestation, we have tissue flaps that grow and occlude the foramen ovale. And with at birth, about 80% of these are going to seal due to the increased and left-sided pressure. A little bit more about that in a moment. And in about 20% of patients, they don't seal. And the flaps may open with increased right-sided pressures, so with a sneeze or a cough. As you'd imagine, patients are going to be asymptomatic. No one's going to be diagnosed with a patent foramen ovale. There's really no way to identify it. But when you have this transient increase in right-sided pressures, this is going to cause a transient right-to-left flow, and that can cause a paradoxical embolism in a patent foramen ovale. Also, we can see it in atrial septal defect when we just have a hole between the two atria. I'm going to cover that in a moment. So about 90% of atrial septal defects are due to failure of the septum secundum to grow and cover its ostium. Others are due to defects in the septum primum. And the classic physical exam finding is going to be a radiating systolic murmur at the pulmonary area with a right ventricular heave due to the increased thickness of the right ventricular wall, and we'll have a widely split fixed S2 because of the increased volume of blood in the lungs. So looking here, just as looking at a normal healthy heart in development. So what we should see, here's our superior vena cava, our inferior vena cava. This is the wall of the right ventricle. This is the right atrium. This is the interatrial septum. And this is the fossa ovalis, or oval fossa. And if we were to look perpendicularly along here, we would see that we have the septum primum closing this side and the septum secundum. And with left ventricular and left atrial pressure increasing, that flap is going to be slammed shut. And then this will seal, except of course in about 20% of people. Now in an atrial septal defect, what we're going to see is we're going to have incomplete growth of, for example, the septum primum or the septum secundum. This is one showing one in the septum primum. And you can see here again on that perpendicular view that we have this very short septum primum, nothing coming down here from our septum secundum, and that is allowing free flow between the atria. So let's talk about paradoxical emboli. And I'm showing it here in an atrial septal defect, but you can see whenever there's a communication between the pulmonary and systemic systems. So patent foramen ovale, patent ductus arteriosus, ventricular septal defect, and atrial septal defect. So imagine, if you will, and you may find it useful to review the video on embolism and infarct, that you have a deep venous thrombosis in a femoral vein, a chunk of that breaks off, and it comes up through the IVC into the right atrium. Now, what would typically happen is this patient would get a pulmonary embolism, where this embolus would travel into the right ventricle, then into the pulmonary trunk, and lodge somewhere in the lung, right? What happens, however, if we have, in this instance, an atrial septal defect, is that this embolism can now enter the left atrium, bypassing the lungs, go into the left ventricle, out through the aorta, and then it can go off, causing a cerebrovascular accident. It may bypass that, head down, end up in a kidney, end up in a spleen. So these are paradoxical emboli. Similarly, if you have a ventricular septal defect, what will happen is you can get the embolism coming through here, entering the left ventricle, and then going out through the aorta. So this is just to help you understand what that looks like. So what are the clinical consequences of atrial septal defects and patent foramen ovales? So atrial septal defect is usually asymptomatic and may not be diagnosed until adulthood. We'll talk about ventricular septal defects in a moment. Those tend to spontaneously close. ASDs do not. And so that's why we tend to diagnose them in adults. Now, initially, we're going to get this left to right shunt. With that left to right shunt, that additional blood flow is going to enter the right ventricle and then come into the lungs. Now, remember, I told you we get increased blood flow. We don't get increased pressure because it's a little bit more blood, but we're not really increasing our pressure. This is different from what we'll see in a ventricular septal defect. And it is possible, though unlikely, that this increase in flow is going to cause eventually pulmonary hypertension and a right to left shunt. We don't see that very commonly with atrial septal defect. It can happen, however, so when we diagnose someone with an ASD, we're going to use surgery to close that. It can be done through a catheter. In some cases, not in all cases, but we're going to close that. That will remove the risk of pulmonary hypertension as well as of paradoxical emboli. Patent foramen ovale, which looks very similar except we don't have a constant blood flow, it just happens intermittently, is completely asymptomatic unless there is a paradoxical embolism. We know that about 25 to 30% of individuals have these based on autopsy studies. So this brings us now to ventricular septal defects, which you can see here. Now, as I mentioned before, just to hit on this quickly, when we have an atrial defect, we're going to get increased flow, but we're not going to get as much, we're not going to get a pressure difference that's going to cause a lot of issues with the lungs. With a ventricular septal defect, you have this muscular left ventricle pushing. So we got a lot of pressure, right? Because you know this from our how fluids work. When you put a lot of pressure here, that pressure is going to be transmitted up to the lungs. So we're not getting just increased flow, but increased pressure. That's going to lead us a little bit more rapidly towards pulmonary hypertension. So almost all ventricular septal defects are going to occur in the membranous region, not in the muscular part of the septum, and most of them will close spontaneously. Now, one thing about ventricular septal defects is about 70 to 80% are associated with other cardiac anomalies, for example, tetralogy of Fetal. A small VSD may be initially asymptomatic, but remember you're getting pressure and volume across this gap. And with a large ventricular septal defect, we're going to get chronic left to right shunting, quickly taking us towards pulmonary hypertension and congestive heart failure, and then the right to left shunt. If this is a large defect, this may present very quickly. These are the characteristics of the murmur, a medium to high pitched, harsh, pansystolic murmur. So as you get clenching of the ventricular wall, you're going to hear it. It's going to be heard best at the left sternal border with radiation over the entire precordium. It's pretty dramatic. And let's take a look here at a very nice ventricular septal defect in the membranous portion of the septum. You can see that quite clearly right here. Now, our final entity to discuss is our patent ductus arteriosus. This takes us again back to our embryology. And as you'll recall, that's that little channel. There's a little tube, but basically a vessel which is connecting our pulmonary artery to our aorta so we can bypass the lungs in fetal life. So in utero, this is very useful. And at birth, when infants take that first breath, they increase their oxygen tension and decrease the pulmonary vascular resistance. Their lungs are going to fill and the pulmonary vascular resistance drops. We also get a decrease in prostaglandin E2. Both of those are going to stimulate closure of the ductus arteriosus in about 1 to 2 days. Now, if in the perinatal time the infant experiences hypoxia, or if the infant has a ventricular septal defect, this is going to increase our pulmonary vascular pressure and sort of slow down or impede the closure of the ductus arteriosus. And so this may remain patent. One thing to keep in mind is that, and we'll talk about this in the video on right to left shunts, there are some defects where you have basically the systemic and the pulmonary circulations running in parallel, not connected, and you need to create a connection. And a ductus arteriosus is a good way to do it. One way to maintain that is to give children prostaglandins to prevent that from closing. So what are the consequences of a PDA? We have this harsh machinery-like murmur, typically asymptomatic. If it is a large shunt, then over time you can get volume and pressure overloads because, again, we have high pressure coming from the left ventricle into the aorta, shooting into the lungs. This can lead to our right to left shunt. Okay, so here are some questions. As usual, you can go ahead and hit pause and see if you can answer them. If not, maybe watch the video again. I hope you have found this useful. As always, please put comments down below. I really do appreciate them. Follow me on Twitter and stay tuned. Take care.